Good morning, everybody. With this, I'll just start with my slide directly. Thank you, Ganesh sir and ENDODIAB team for having me here again. Approach to a child with hypothyroidism. For the next 20 minutes, I'll try to cut short time as far as possible. You can focus on the left side, which I have developed through ChatGPT. So when I was given this topic, how do I develop a good understanding? I just put on perplexity, which is I'm doing I am pro subscriber. This is a simple slide. Over the left hand side you can see approach, one child, screening, imaging, identification, treatment, follow-up, monitoring. That's it. That's my entire topic. So contents of this topic will be held in like textbook like fashion, which I will not be able to justify in time, because I have been delivering these sessions for IAP as well. So I have just, first agenda will be what is the importance of newborn screening for congenital hypothyroidism, which sample, timing, time to perform, whether it should do universal or selective. This will all be discussed in a very brief manner. Introducing this topic, you should understand that thyroid hormones are quite essential for the growth of an individual, especially the brain growth. So you can see this is the telltale figure, which you can see here. The person born with this picture, which is very rare to see nowadays. We screen them early. Unless you treat them on time, they can go with mental retardation and growth failure. So it's a newborn condition itself. It's a group of complex disorders. It is not simple, though it looks simple. It's a very common endocrine disorder. The numbers are very big. You can see it is most common preventable cause of mental retardation, and it is often subtle or absent at birth. And myelination, as I had shown in the previous diagram, is most crucial in the first year of life. Again, simplifying through textbook teaching, thyroidism in children is divided into congenital versus acquired. Acquired again divided into primary and secondary. And these are types of congenital hypothyroidism you can see. I have taken this from Digroot textbook of endocrinology, where they have beautifully given you the diagram where the thyroid analogen, then migration, differentiation, everywhere you need to have a proper functional thyroid gland. And functional thyroid gland needs the factors, growth factors should be developed correctly. And the number is actually screening. 1978 onwards, they have developed the screening in France. So I think in Kerala, in the last 10-15 years, we are doing it universally in every private hospital and government setup. And I wish every state in India is also doing that, including Karnataka. It's involving the child to blossom. So we should give the chance for the child to blossom. And these are the symptoms like butterfly of thyroid. You can see the symptoms of thyroid in children. It can be as simple as dry skin, large for date, which will be the goiter, postpartum, very varied symptoms. And one symptom will be different from other person. So initially you can have macroglossia, the midline defects like umbilical hernia, development delay, but definitely you need to have a blood test which is done early in life. And this is a landmark study which is published in 1972, showing that IQ and congenital diagnosis, actually at age of onset, if you do it, it improves exponentially. You can see the numbers, and this is the Journal of Pediatrics 1972, shows that starting treatment within this much of duration of time improves the IQ to at least as what desirable for that individual's potential. Again, evaluation of primary hypothyroidism, you should take the history in particularly, consanguinity, perinatal history, maternal history, iodine exposure, which we have already ensuring universally, dysmorphism, anomalies like heart, brain, gut, all those things should be taken up. You can see the picture, anybody can guess, it is called Bamford-Lazarus syndrome. So it's one of the conditions where you can pick up with growth defects as well as ventilation dependency. You can see all these signs in a very easy manner if you are following them early itself. And imaging is quite crucial because thyroid gland is one of the glands which cannot be picked up radiologically initially, but you need to do technetium thyroid scintigraphy whenever indicated or whenever available for that before starting for any therapy, which is going to be at least lifelong in some cases. And some people also do the AP X-ray of knee, which to pick up the early onset itself. Coming back to what I was touching upon, in 2012, you can see that the data, yesterday we had discussion in our Friendos group, one of the doctors posted there, that we don't have a data which is universally acceptable. But you can see in Kerala, we are catching up. And this is the Kerala data which I have shown you. From 2018, 100% coverage in government hospitals, 75% coverage in private hospitals. The number has grown to nearly 100% in the last 2 years. It is entirely the work of the IAP and the endocrine community. This is the publication which I had presented in IOTA, it is the Asia Oceania Thyroid Congress, where I was part of the study, where we had initially done without universal newborn screening, and after screening what impact it has. This is from the Amrita Institute where I had worked. So we had checked for the conditions, what is the dose ideally required, what are the indicators of permanence, and what is the effect of screening of newborn screening. As a pediatrician or person practicing endocrinology, we should definitely understand the neonatal physiology, and TSH surge can be blunted in some people like shown here. This is the preterm and the term variation. TSH is the most reliable indicator in the initial first few months of life, following which T4 also can be quite useful. And cord blood TSH is not affected by this surge of TSH. That is why we should definitely screen with cord blood whenever it is possible. It is actually less expensive and not painful at all. If not possible, you should do the postnatal sample 48 hours before time, after time, because before 48 hours, if you are doing postnatal sample, it can have high positive, false positive rates. This is a database which again I will not share, I will not spend more time. This is from the Cloharty textbook of neonatology, showing that from birth till 18 years, there is a description of the population based cutoffs as per the date of birth also. This is the again a textbook description. So I'll just put it in one table again. The sample for screening should be definitely cord blood when in most of the situations, as I have shown you the indications here. But in postnatal sample, you can also screen other inborn errors, and you can see that neonatal surge is actually one which should be kept in mind, and you should need special assays like dried filter paper for issuing heel prick sample. Whereas cord blood is quite simple to do, only small indications like neonatal asphyxia may affect that. So which test to order again? It can be either primary TSH, backup T4, which we all do. The American teaching is primary T4 and backup TSH. And what we usually think about, IAP also endorses a combined T4 TSH approach in the 20th day at least by that time. So this is what the data again shows you neonatal age group. Again age-wise cutoff is there for the preterm and term. And going ahead, this is the one, the Cloharty, which tells you free T4, it should be done wherever assay is doing free T4. Second sample for screening is definitely required in some cases where you have an indication like preterm, IUGR, sick neonates because they have an illness initially. Then you have twin pregnancy, Down syndrome, and if you have taken a sample after blood transfusion, because that is also one indication you should remember to do a second sample for screening before jumping into diagnosis of congenital hypothyroidism. So what do you do when you have borderline TFT, borderline high TSH with normal T4? Again, as I have told you, repeat the test after 2 weeks. No hurry to start treatment. Nothing will happen for that child, at least 2 weeks. If it is beyond 3 weeks, it persists. More than 10, we take it. Even with normal T4, we should start treatment, is what they mentioned. And low T4 with normal TSH, again, other side, we should always remember that because central hypothyroid can be only screened by this method, because they will have at least low range of TSH and at least a very low value of T4. Only with that we can pick at that. So summarizing this stat, TSH is the most important indicator. It is reliable except in some condition which I have shown you here, and more than 20 in the first 2 weeks, beyond 10 in the next 2 weeks is what IAP also endorses. Total T4 is what universally told to be better. If you have free T4, you can reliably do it, definitely better. Supplemental hypothyroidism again is a more common entity in children, which I will also tell you. So TSH based screening is more sensitive and specific, but may miss the central hypothyroidism which I require T4. But T4 based screening can identify both primary and secondary, but may miss the compensated hypothyroidism, and again it can give you high false positive test also. So coming to some cases which I have seen and also Dr. Ganesh sir has shared with me. One child presents with a very short stature, and that child presented late to us, around 10 years of age, and the child had TSH of more than 100. So one of the indications you should screen is short stature. This may be the monosymptomatic presentation, one case which I have seen. So this brings to the question, what is juvenile hypothyroidism? Previously we called juvenile, now it is called early onset of hypothyroidism. It is onset in childhood after neonatal period. It's one of the more common conditions. Autoimmune conditions are highlighted in that condition. Again, the subset is there in this. So some conditions like infiltration of the hypothalamus very rarely, and growth hormone therapy on GH, they are all having a secondary hypothyroidism also there. Summarizing the neonatal issues again, congenital dysgenesis, central causes, transient causes, many causes are there in this table, again important to recognize them early. So with this background, next 10 minutes, I will like to spend you how we can simplify treatment for you. So with the real life case scenarios. So first case here, an 80-year-old girl comes with newborn screening, normal, follow-up uneventful, presentations, acute presentation with abdominal pain, menorrhagia, TSH value of 150 and FSH value of 9.7, LH value of low. Very simple. What is it? Bone age shows significant delay, not the progression of puberty. So it is definitely called von Bringbach syndrome, which is a FSH spillover, you can see. And the second case, a 12-year-old male presents with newborn screening normal, follow-up uneventful, presentation subacute, presents with weight gain, fatigue, acanthosis nigricans and goiter. TSH of more than 150 again, anti-TP of more than 1000. Simple, but HbA1c is coming to 8%. He is gaining weight for the last 2 years. It is a case of insulin resistance induced hypothyroidism. So again, I should summarize again, monosymptomatic presentations of hypothyroidism is very much important. It can be either short stature as I had shown you, delayed puberty, goiter, primary amenorrhea, refractory anemia, because anemia we all say by 12 years of age, at least you should check them. Peripubertal menorrhagia, precocious puberty, you can see all these signs, but don't forget, poor scholastic performance, because that is one of the things which often children, competitive world tell us, parents also tell us, not able to memorize properly. There may be many causes, but nothing harm in screening for thyroid, but if it is symptomatic and treatment is always beneficial. This is a case report of juvenile hypothyroidism presents with hypertrichosis, multicystic ovaries and pituitary adenomas from Kolkata. And so many case series are also been published world on Kerala, in Kerala and in world also. This shows you that autoimmune etiology is one of the most important etiologies for juvenile hypothyroidism, and some people also have ectopic thyroid and secondary hypothyroidism also. So again, you should understand it is a firm goiter. It is some cases goiter may be not present. Anti-TPO and TG may also be positive. Family history can be even picked up by diagnosis. Now we are not finding endemic iodine deficiency and selenium deficiency, but they may definitely be ascribed to the goiter. So this is a text article by ITS President Dr. Krishna Sheshadri sir, published in 2016. You can see here that time itself so many guidelines requirement was understood. Subclinical hypothyroidism in children means free T4 is normal, TSH is just above the upper limit of normal. It's actually increasing in time. The reason is because obesity. You can see the obesity involves the axis. Weight loss will normalize the axis. Leptin is the promising link between obesity and TSH levels. Insulin resistance is like an iceberg phenomenon. You can see obesity only, but remaining things are below the iceberg. And Hashimoto thyroiditis is one of the important things to be screened in children also. That is why with this summary it will give you help, because metabologenetics with acquired hypothyroidism, you can see celiac disease is one of the things in North India. In North Karnataka also we have. Cystic fibrosis is another genetic condition. Turner syndrome, Down syndrome, Williams syndrome. Remaining are very rare. Dr. Nagesh had described SGA, CKD, other condition, but definitely screen the simple things and then diagnose and treat them correctly. Because benign conditions like this evolve very slowly. Prediction is important. Do the screening with all these tests and don't start treatment unless it is actually indicated beyond 6 to 12 weeks if you are finding an increased TSH. Third case, a 14-year-old girl with menarche of 12 years, normal menarche, no family history, but you can see the concern was not growing properly and TSH of 9.1. Sir has also shown you some diagram here, Dr. Aganesh sir's case. This is actually a case of submental hypothyroidism, submental goiter. So the goiter is actually come below this area. So that means that they have only seen recently. It is not lymph node. The neck has actually having a tissue over there also. So actually ectopic tissue, that is a double goiter. Over there also some tissue is developing and there is also a neck tissue also. Definitely it is unusual to present, which is why we should tell the parents that it requires to be treated early itself. And 15-year-old girl with headache for 3 months, aggravated for 2 weeks, is the last case. You can see not associated vomiting. A radiologist told it is macroadenoma and it has scared the parents also. Actually it is a case of TSH thyroid adenoma. It is actually a case where thyrotropin by such stimulation, the TSH stimulation was there. It is a non-functioning tissue and primary hypothyroidism, definitely it can be screened. You can see the impact of treatment after starting Hyroxin 100 microgram, it actually went away. So vanishing tumor-like syndrome, it's published in JCM by the Indian group itself. So I think summarizing this, it is actually a very unusual to see early, but it should usually presents with short stature, delayed puberty, diffuse goiter, poor scholastic performance, and sometimes as a supracellular or cellular mass. Unusually with precocious puberty, limping gait, acute abdomen, so many variety of symptoms like Pandora's box, calf muscle hypertrophy, headache, visual loss, and also dysphagia like lingual thyroid. Some patients also tell us. That is why we should do follow-up. The first case we followed up, we did a follow-up which was very good. After 5 months time, the child improved and actually gained height as well. You can see that abdominal pain, menorrhagia was suspected, ovarian cyst was actually benign, which went away. Thyroxine therapy improved everything, and it has actually helped you. I think I'll end with this case. A 13-year-old boy with poor gain, isosexual precocious puberty, upper segment, lower segment reduced, bone age actually reduced, and again what I had told you is the male child of this variant, Van Wijk-Wijnberg syndrome. So we can see TSH of more than 100, T4 is low, and you can see this, we can see that increase, which is happening because of the FSH spillover. So thyroid is required for bone metabolism also. It includes the skeletal formation and growth hormone also. This is from juvenile hypothyroidism in overall world. You can see that skeletal tissues everywhere maturation is impacted, and this is a table which you can see and understand. Primary hypothyroidism is more common than secondary causes, and you can see secondary means pituitary causes. Goiter is more often the primary causes. Antibodies positive more often the primary, whereas you can definitely find concurrent hormone deficiency in secondary causes and absence of goiter in the secondary causes. And actually after finishing my DM, one of my friends published this along with my group, and we had a publication IGM last year. We published this data on 10 years record of census of partial newborn screening in that time, and we got initially only 15 patients, 20 patients, and number grew to 233 patients at the end of the 10-year study. Number is less, but we had screened properly and found that after starting newborn screening, the time required to treatment has reduced from initially 45 days to 10 days. That means impact on growth is profound in such individuals. So I think I'll finish in the next 2 minutes by telling you that a controversy exists on selective versus newborn screening. The cost versus benefit, I'll end in 1 minute. So newborn screening is not picking up in pace in India. Guidelines are there in ISPAE. You can see that guidelines are very clearly told whatever I have told you so far. Screening is very important. And heel prick or cord blood is anyone is better, whatever you do. But less than 20 is what you expect to happen. If it is more, definitely start treatment. Check for compliance also, because people may not give them properly, and sampling is also important. And imaging, again guidelines tell you imaging ultrasound thyroid is preferable whenever in 1 year of age, but before that you should do the nuclear scan. Treatment again started only when you are indicated. Early onset definitely indication is required. Dose is 10 to 15 microgram per kilogram in neonatal period. Follow them at 2 weeks, then 1 month, then 6 months, and 1 year for puberty. Hearing test is required, and congenital malformation. That is only 2 differences from the adult thing. Last question, whether it is lifelong. Everybody will ask you this question. So that you should understand some conditions are transient, some conditions are permanent, and conditions for permanent, remember to tell them development delay and neural damages and height is one, preferably benefited by growth, and follow up by growth chart, Tanner staging, and development is always indicated. Early reevaluation is often required when you have an absent family history, normal imaging, and lower dose requirement at 6 to 12 months. And back to my diagram which I came to, when you see simple things, you do simple, but complicated things, you should do genetic testing. Some genetics tests I have described, I have not done so far, but required, take assistance of your genetic colleagues. So summarizing that, my entire talk, management is of hypothyroidism, contrasting to neonatal, juvenile hypothyroidism is not very rapidly required. We can follow them correctly. For school performance, inactivity, insomnia, behavior, you should definitely give them priority. Observe for headache when you are treating treatment suddenly, because they can actually worsen the treatment and cause pituitary apoplexy if you are giving fast treatment in juvenile hypothyroidism. This is the dose requirement in the juvenile hypothyroidism, not the congenital hypothyroidism. Definitely monitoring required, and I think I had just done a work for endocrine awareness for the public. Whatever we say had to go to public. This is the summary. Mnemonic be prepared for the endocrine society. Thyroid is the mnemonic. TSH early, heel prick, yellow eyes, whatever we say, public will come to you only if you tell you are the persons for thyroid. And we also in ESI, we have done some work for public awareness for leaflets. This is what we did as a group, and it's available on the website. Thank you very much.
Thank you, sir, for presenting entire hypothyroidism in 15 minutes, actually, starting from congenital angiola, and made us understand too. So the forum is open for discussion. Any question, sir will be able to answer, take it. Sir, one question. You had put that if there is late preterm or prematurity, should we, if the initial TSH is normal, should we again repeat after 2 to 3 weeks?
Yeah, because you should take corrected gestation age also. Because you should take the womb time and out time. They should have the corrected gestation. We don't start early itself. I think 2 weeks time at least, as I have told you, we do. But repeat sample is required because initial surge may be missed or maybe. But cord blood if you have done and 14th day if you have done, if you are finding a value which is not in the range, definitely indicated to start. But growth affected, so we should definitely take one-to-one case. Recently I had a patient of 9.5 TSH, parents were anxious whether to start or not. I did not start. Finally they went to somebody and started. So we have difficulty in explaining, losing time, but if you tell them honestly speaking, they will come back to you with the